morning, everyone. Welcome to the Docuity app. Welcome to our SKD series. Our SKD series is SKD stands for our first clinical oncologist in Malaysia, who is our founder of the National Cancer Society Malaysia. We do this every month at the end of the month regarding the cancer of the month. And this month for March, is about colorectal cancer. National Cancer Society is an NGO, a non-profit organization focused on screening, education, and supporting cancer patients. If you know anyone with cancer, get in touch with us and we will help them out. So please help me welcome Mr. Ussof Eskaandar Hussain. He is a distinguished surgeon specializing in minimally invasive surgery for benign and malignant conditions of the colon and rectum. He is currently based in Sunway Velocity Medical Center as a general surgeon and colorectal surgeon. With a career spanning over a decade, Mr. Ussof has garnered extensive experience and expertise in colorectal surgery. He holds an MBBS from IMUM and a Master's in General Surgery from UKM. His journey includes notable appointments such as colorectal surgeon and general surgeon at Hospital Sultan Haji Ahmad Shah, Temelloh Pahang, and colorectal fellowships across esteemed institutions in Malaysia. He has also been recognized for his excellence, receiving awards like the State Quality Achievement Award and Best Student Award for his academic prowess. He is a dedicated educator, an awesome researcher, and he has many initiatives aiming to improve surgical care. Without further ado, please join me in welcoming Mr. Ussof Eskaandar Hussain, a leader in the field of colorectal surgery and a passionate advocate for patient well-being. Take away, Mr. Ussof.
Thank you very much, Jason, for the kind introduction. Good morning. Thank you to everyone who has joined the webinar today. I am Ussof Eskaandar, currently a resident general as well as colorectal surgeon attached to Sunway Medical Center, Velocity, Kuala Lumpur. Without further ado, let's start our talk today, our discussion today. First and foremost, thank you to the National Cancer Society for giving me this opportunity to talk in a platform of a distinguished, well-renowned person who we owe a lot, this country owe a lot, a person who have started the oncology services in Malaysia. All right, I'll start sharing my slides. All right, so just run through of the topic, right? So basically the topic that we are going to talk about is about colorectal cancer in relation with the Colorectal Awareness Month, which is the month of March. So what role does the primary care play in order for us to win the battle, or at least to get our community or population screened for one of the commonest cancer in Malaysia now? Basically, it is the commonest cancer, second commonest cancer in Malaysia, but it's the commonest cancer among the male and the second commonest cancer among the female, right? So there's a paradigm shift. There's a shift from the usual common cancers in Malaysia 10 years ago, which was lung among the male, but now it has become the colon. So basically, I just want to make everyone in the participant aware that there is something known as the blue ribbon. So the pink ribbon is very famous for breast cancer, and then these are the other ribbons that is available. But we have our own ribbon as well, which is the blue ribbon, which is for colon cancer. Okay. So basically, colon, when we talk about colon, basically we are talking about large intestine. Okay, not to say that we don't have small bowel cancers. We do, but it's not very common. And most of the time, in my limited experience, is usually very rarely adenocarcinomas, but mostly lymphomas. Okay, so usually patient comes with intestinal obstruction and they have lymphomas of the small bowel or gastrointestinal stromal tumors. So when you talk about colorectal cancer, basically we are talking about cancer of the large intestine. Okay. So when we deal or when we talk about the management of colorectal cancers, we will divide the colon into two parts. The cecum, the ascending colon, the transverse, and the sigmoid is considered as the colon. The rectum, the middle rectum and lower rectum is slightly different because the management differs from the standard management of colon cancers. All right, so let's run through what I'm going to talk about today. So basically, we start off with a clinical scenario, a true case, a patient of mine how was the journey from the very beginning when she had the symptoms, and how was she screened, how she ended up with me, and eventually how she is now. Okay, so then we talk about what's happening in Malaysia. I will try to introduce the concept of opportunistic screening, the pathogenesis. How can we tackle this cancer? We need to know how does the cancer develops. Okay, so it was briefly on pathogenesis. So what happened is when my FI immunofluorescent fecal occult is positive, is it cancer or is it something else? Briefly on benign versus malignant polyp and what is changing. So basically we talk a bit on the update, what is changing in colorectal cancer management compared to 10 years ago. All right. So a true scenario, okay, this is Madam N, okay. She was a 58 years old Chinese lady, came to see me somewhere end of February, okay. So the complaint was very straightforward. She had painless colorectal bleeding for 1 week, okay. That's all, okay. So the blood is mixed with stool, no abdominal pain, no constitutional symptoms. She's perfectly well. Okay, comorbidity, just hypertension on single agent. So she went to first to see a regular practitioner. Okay, she got terrified that there was blood in the feces, and the general practitioner examined her, and he made an impression that maybe it's a bleeding hemorrhoid, and gave her medication and discharged. But the symptom was persistent. So after 2 days visiting the general practitioner, she went to see another doctor in the hospital. And the doctor decided to examine her and subject her for a colonoscopy, right? But in view and due to time constraint, because she went to a government facility, so then she decided she wanted to go to a private hospital. That's because she was a bit worried that the symptom is persistent. She came to see me. Okay, so when I saw her, she was well. She's pink. Abdomen was soft, no mass. But actually, I don't feel any mass. So I subject her for colonoscopy. This was a colonoscopy. So the rectal bleeding was actually from a huge lesion in the sigmoid colon. Okay, so the initial biopsy came back as high-grade dysplasia with adjacent invasive malignancy. So following that, I did a CT scan. You could see here in the CT scan, the arrow is pointing to the thickened area of the sigmoid colon with a possible intraluminal mass. So it is an intraluminal malignancy, all right? So she went for surgery, okay? She went for a laparoscopic anterior resection. This was the pathology report. It is cancer. It is a PT1 cancer, okay? Something good for her is that she came early. She didn't wait for the symptom to resolve at home. As soon as she realized 3 days symptom not resolving, she came early, and we managed to diagnose her early, managed to stage her early, managed to operate her early, and she went back 3 days after the surgery. So this is a nice story to elaborate, but unfortunately, not everyone shares the similar experience. Okay, so and always we feel that rectal bleeding is almost always equivalent to hemorrhoid, which is not always so. Okay, so in the era now that we notice that the colorectal cancers are getting more frequent, more people are affected. Okay, so let's go back to the topic just to remind us that how does primary care physicians, can be general practitioners, can be medical officers, can be the community health nurse, can be the family physicians, what are their roles in order for us to get our population get themselves checked up, all right? So let's see what is our local scenario, okay? So in global cancer burden, yeah, it's increasing day by day, almost 22 new million cases worldwide per year. This is cumulative for all types of cancers, okay? It has increased 75% compared to 2008. It can be due to more reporting. It can also due to the cancers are getting more frequent, okay? Or it can also be due to awareness. People go and check themselves more frequently, so you tend to detect more cancers. But in Malaysia, breast and colorectal cancer, that's the commonest cancer in Malaysia, okay? And unfortunately, 60% of them come in stage 3 and stage 4. Madam Ann came in stage 1. So what is the advantage? Recovery is good, recurrence rate is less. She does not even need chemotherapy post-operatively because the tumor is removed, okay? And this is considered as a cancer preventable death. The sooner you detect, the better is the outcome, and you can prevent the cancer-related death, okay? This is a report from our National Strategic Planning for Cancer Control up to 2025. If you could see here, the colorectal cancer is highest among the male, 14.8, whereas in female it's catching up. It's the colorectal cancer is second. The first is still breast cancer. By image, you look into the image, this is colorectal highest among the male, and breast is among the females, colorectal is second. So gone were the days where you always say lung cancer is the commonest cancer in male. Now it is colorectal cancer among the male. Okay, so if you look at it, this is our local data. What is the relative survival rate? So the diagram is self-explainable. The earlier you come, the better is your survival rate. And if you look at the 5-year survival rate of colorectal cancer, it's 17.3%. Okay, this is the data from 2016, and this has changed. This has changed now, so you can go up to 30% now if you could address the primary lesion as well as the metastasis. So things have changed, the practice has changed, technology has improved, so the survival has improved as well. Okay, we talk about it later. So these are our data. More people we see a lot of people coming in stage 3 and stage 4. Okay, stage 4 up to 40% in both male and female, which is very sad. Okay, so second commonest cancer in Malaysia, highest among Chinese ethnicity. Not sure why, but this data has never changed for the last 10 years. If you look at our local statistics, 10 years ago, it was still highest among the Chinese ethnicity. Now it is also still highest among the Chinese ethnicity. Okay, so the incidence has increased after the age of 55. So there's a change of practice now. So previously, the recommendation is to start screening from the age of 50 years old. Okay, now the age has been brought down to 45 years old. Why? Because you see more young patients coming in with colorectal cancer. So it's a national policy as well as international policy that you have adapted that screening has to start earlier now, which is 45 years old. So if you look at the age standardized incidence and mortality rate, it's still the second highest cause of mortality and morbidity in Malaysia after breast cancer. Okay. So is the awareness improving? Yes. Okay. There are several local studies, local data that shows that the public is more aware of colorectal cancer, but I feel it's still not enough. It's still not enough. You still have to reach out to the community just to make them aware that there is such thing as colorectal cancer. It's the commonest cancer, and there is very simple way to screen you for cancers. Okay, so let's talk about the opportunistic screening. So this is something that I feel that very relevant, very important to be adopted by our primary care colleagues. Okay, so basically you offer them a test. So they come to you to see you for some other problem, some other ailment. You offer them, would you like to check on whether the presence of microscopic blood in your feces? So it's a free test. It's a free test which is offered as part of the national screening program in the government facility. And you can get it done even in general practice. Okay. So basically, when you talk about opportunity screening, someone asks the doctor for a check, or you yourself offer the patient a test. So basically, what is our intention? You diagnose the disease in its early stage or in pre-cancerous stage, offering patient for cure. Cure, that means a resection, a chemotherapy, whatever it is, our aim is cure, no, not palliative. So this is actually a poster from the National Cancer Society. Okay, so this is basically an awareness poster telling about what is colorectal cancer, what you can do about it, how can you minimize the risk of getting colorectal cancer. But first on the list is still a screening test. Okay, so in Malaysia, this is the adapted screening test, which is the immunochemical fecal occult blood test. Okay, so let's see, what are the primary care physician's role? Okay, patient education, offer screening tests, offer colonoscopy or referral for colonoscopy in high-risk patient, and explain the pathway. Okay, so basically you have to reassure the patient that a positive fecal occult blood test, it's not equivalent to colorectal cancer. But a positive fecal occult blood warrants you to have a screening colonoscopy. Okay, because even if you have a polyp in the intestine, which is a pre-malignant condition, you could still have a positive fecal occult blood test. Okay. So what are the stool-based testing that we have in the market? Okay, we have the Colorectal fecal occult blood test, the fecal immunochemical, which is in Malaysia. The third one is the multi-targeted stool DNA. For all these three, we are using the second one, which is fecal immunochemical immunohistochemical test. Why? Multi-targeted stool DNA is a bit expensive. So when it's expensive, you need to choose a modality which is economical, easy to be done, easy to be processed, and is accessible to our patients. Okay, so stool DNA, it's not adapted. Colorectal fecal occult blood test was initially started in Malaysia, but they noticed that a lot of interference in terms of diet. So certain types of diet can alter to give you a false positive result. For example, if you have meat in your meal a day or two before they collected the fecal sample, that will give you a false positive result. So as it's been out of favor, now we go to IFOBT. Okay, a very simple test. The patient has to acquire the stool sample and then send it over to the lab. There are test kits available. That means, like how you do your saliva test kit for antigen COVID test, there are test kits available. But then in Malaysia, it has not picked up yet compared to in the West. For us, we still get the stool sample. The patient has to send it over to the lab. To the hospital or the clinic facility which offered you the test, and they will get the testing process. So awareness has to start with patient education. So they must be aware. So what are the common signs? Okay, the signs and the symptoms of colon cancer, it's not the same in all people. I'm sure all of you are aware what are the common symptoms, but it's not the same. That means that some patients may not even have change in bowel habit. They just have blood in the stool. And all you know that there is, like my patient of mine, she didn't have any chance of bowel habit. Her bowel habit was normal, but she had blood in the stool. Okay, good for her. She came early and she managed to diagnose early. Okay, so the other symptoms like cramping, bleeding from the rectum, blood in the stool, bloating, these are the symptoms that they might be present or might not present. Okay, in all patients. Okay, this is typical textbook description when they say you have pencil lights to pain defecation, tenesmus. Tenesmus is a sense of incomplete emptying. So they go to toilet, they want to empty their bowel, they empty their bowel, but they still feel there is something left behind. Okay, so there is a sense of incomplete emptying, bleeding, pain, and fatigue. Fatigue is basically due to anemia, due to chronic blood loss. Okay, so this algorithm, I think all of you are aware, this is from our local clinical practice guideline on colorectal cancer. So basically, they've divided the patient into three groups: average, moderate, and high risk. And in average group, in an average risk, you can still subject them for a fecal occult blood test. But when you have patients in category 2 or 3, straight away refer for colonoscopy. Okay, so I think the criteria, the group, what is category 1, what is category 2, it's available in the CPG for us to just for our reference. Okay, this is a newspaper cutting uh, 10 years ago. 10 years ago. Okay, if you look at this data is in 2002. Okay, it's 12 years, 20 years ago, sorry, 20 years ago. Okay, if you look at this, it shows in 100,000 population, it is still highest among the Chinese. We could see 59 in male and 64 in female. Okay, so this hasn't changed. 20 years down the line, we still see there is some ethnicity difference. The Chinese still has higher incidence of colorectal cancer compared to other ethnicity. Why? Not sure. Okay. Right. This is basically a screenshot from our local clinical practice guideline, who are considered as average risk, who are considered as moderate risk and high risk. Okay. A simple way to remember it is that as long as the patient doesn't have any family risk factor, he's considered as category 1. And if family members has colorectal cancer, then it's considered as moderate risk. If there is element of genetic, that means any family members develop colorectal cancer before the age of 50 years old, there may be a possibility that they have inherited genes for them to predispose them to have colorectal cancer. Okay, so they are considered as high risk. Okay, category 1, you can offer fecal occult blood test. Category 2, category 3, straight away to colonoscopy. Because even if you have a negative fecal occult blood test in patients belonging to category 2 or category 3, I still do a colonoscopy because they have risk factor. Okay, how frequent, how soon, how frequent do you have to monitor them? Okay, for fecal occult blood, yearly. For since you are not doing stool DNA test, for colonoscopy is 10 yearly, depending on the colonoscopy finding. If there is any finding in the colonoscopy, in the screening colonoscopy, the interval will change accordingly, right? Okay, so that's about the screening in Malaysia. So I hope you could follow me so far. So what can we just revise to this point that colorectal cancer is the commonest cancer in male, second commonest cancer in female, the second commonest cancer in Malaysia. Population-wise, screening, ethnicity difference. Third, still patients are coming in stage 3, stage 4 because most of them regard colorectal bleeding, they think it's just hemorrhoid. Okay, all right. So they need to be a paradigm shift in terms of thinking of our population to get them screened for colorectal cancer. Okay, I wanted to revise a bit on the pathogenesis because why are we advocating on screening? Because these cancers in 80% of the population doesn't happen in one day. Okay, it is not a cancer that happens in months. It's not cancer that happens in a year or two. It takes years. It takes a decade in order for a polyp to convert from a benign polyp to a malignant polyp. Okay, so we look at this diagram here. Okay, this is just to remember what we have studied during our student days. Okay, so from a small polyp, from a small benign polyp, for it to turn into an advanced polyp, which is a large benign growth, it takes 10 to 20 years. Having said that, if you could address this polyp, if you could put in a colonoscopy and remove this polyp, basically you are preventing the patient from getting cancers because the polyp is no more there. You're not giving time for the polyp to turn from a benign polyp, small polyp, to a large polyp and eventually becoming cancer. So that's the reason why we want to catch the patient when they have polyp. How do you know? If the fecal occult is positive and the patient does a colonoscopy, there is a polyp, we remove it. Okay. Once you remove the polyp, there's no risk because the polyp will gradually undergo mutations in the oncogenes, tumor suppressor genes, and turns into a malignancy. Okay. All right. So basically, if you could remember one picture from all my slides would be this one. Okay. From a normal intestine, we should look at that. Look at a small polyp. The polyp becomes malignancy, full blown malignancy. This is preventable. So if you come at this, when the patient is picked up during the second stage of this diagram, you remove this polyp, you reduce, you will eliminate the cancer risk in them. Okay. Okay. Let's talk about something about colorectal cancer itself. Why do people get cancers? Okay, you have to remember the commonest cancers, colorectal cancers, is still it's not genetic. Okay, the commonest is still sporadic. That means out of nowhere, one family members get a colorectal cancer, and you look through the family tree, none of the family members has colorectal cancer. So most of them they are sporadic, one-off. They have just genetic alteration in the tissue. Only 20% of the colorectal cancers are familial, okay, where there is genetic alteration in the germline mutation, okay? So what you see in the normal population, it's still a sporadic, okay? That means they have no family history, they have no family members with colorectal cancer, but out of nowhere, they have genetic alterations in tissue, making them to have colorectal cancer, okay? So there's a lot of interplay in terms of diet, environment, the gut microbiome. You cannot point exactly, oh, this is the cause for this patient to have cancers. Okay, so they have studies. They have shown that high intake of red meat is associated with higher chances of risk of cancer. These are all what do you say studies, but you cannot prove it 100%. But this is a risk factor that when you have high intake of red meat, you are more prone to develop colorectal cancer. Okay, so we talk about the small subset of young patients. So young, we consider anyone less than 50 who has cancer. We consider them as young onset colorectal cancer. So when you have any family members who develop colorectal cancer less than 50 years old, please get yourself and your siblings screened. Okay. So who are the one at risk of developing it's the young onset. So cancer in less than 50 years old, it's getting up. More patients are young now. I've seen cancer in as young as 22 years old. Okay, colorectal cancer 22 years old. And surprisingly to say, if you want to say that in Malaysia that the reason why you have more patients with colorectal cancer because there's change in dietary pattern, I have also seen our local natives, orang asli, coming in with colorectal cancer. So there is no 100% association of dietary and colorectal cancer. Sometimes there is something else. There's some other interplays which we cannot conclude. Okay. So genetic testing is only recommended in young patients with colorectal cancer. Okay. All right. So let's see. This is the pie chart. Okay. Commonest is still sporadic. Familial, it's about 20%, and in familial, we have the few common, the established syndromes which is associated with colorectal malignancy. Example, Lynch syndrome, FAP. Okay, all right. Now, in hereditary colorectal cancers, these are the few examples of hereditary cancer. Okay, we have the non-polyp one. That means the patient develops cancer out of one polyp. We have the one that develops from polyp. What is the difference? Is the number of polyp. Okay, in FAP, the polyps are in hundreds. Okay, and the duration of time this polyps turns to malignancy, it doesn't follow the normal pathway of 10 to 20 years. Okay, they can get cancer as early as 3 to 4 years after the when you diagnose them to have polyp. Okay, this is an example of FAP. There's carpets of polyps covering the intestines. How do you know that you have this in the family? It's an autosomal dominant condition. Okay, that means there must be a family member who has a colorectal cancer at a very young age. Okay, so if you notice that your uncles, your aunt, or your parents, your father had cancers in the colon before the age of 50, get yourself checked. Okay, all right. What to do? My FOBT is positive. Is it cancer? It is not equivalent to cancer. Okay, this is a local study, a Malaysian cohort study conducted by University Kebangsaan Malaysia. Okay, basically looking at a screening fecal occult blood test in a population of 237 samples. Okay, so basically they had fecal occult blood test in 237. So out of that, only half underwent colonoscopy, 50%. Okay, because 17% refused, 17% uncontactable, 10% pending appointment for colonoscopy, and some were referred for colonoscopy to another facility. Okay, so basically, what do you want to see? Let's see how many positive colonoscopies are there. Out of that, 44% was normal colonoscopy. That means they had a positive fecal occult, but the colonoscopy was normal. Good for them. Okay, but there was 36% of them who had polyps, and out of that, 4% of them had colorectal cancer from the very initial screening colonoscopy. So what we want to target is this group, this 36%. So this 4.8, that means we already diagnosed them. But what we want is to prevent this 36% of the sample from developing cancer in long run. Okay. So how does it prevent cancer? Is that you put in a screening colonoscopy, you find a polyp, you remove it. Okay. So it could prevent more than 2/3 of colon cancer because you detect the polyp at the initial stage, okay, before it has turned malignant. Okay. So basically, you can have benign polyp or a malignant polyp. So basically, a polyp is just an protruding or pouching of the mucosa, which consists of abnormal mucosa. Okay, so usually the cancer will develop from the mucosa and progressively it grow inwards, involving the stalk, breaching the submucosal layer, going into the muscle, going to subsclerosa, and then only infiltrate to adjacent organs. So basically, it's a process. Okay. So if you get a patient at the stage of polyp, or if you get a patient in a very early polyp, in stage 1 polyp, you remove the polyp, it's considered as a curative resection. Basically, you have removed him from risk of developing cancer, and you can do his surveillance accordingly. All right, this is one example how you remove a polyp. You just snare it out. Okay, there's another example where you do a mucosal endoscopic submucosal dissection to remove polyp, especially flat polyps. Okay, this is a polyp which has pedunculated. It has a stalk, whereas this doesn't have a stalk. This is another example where you elevate a polyp, which is a sessile polyp, and you remove it. Now, all these procedures are done endoscopically. That means it's not surgery. It's just when you put in the colonoscopy, you take the opportunity to remove the polyp. Okay, all right. So basically, up to now, I think I've emphasized my point and how we want the change in practice to happen in Malaysia. Everyone is advocating on colorectal cancer. You see discussions of colorectal cancer, a lot of platforms. Everyone is talking about it's a common cancer, it's catching up. So where can we initiate a change? I think the primary care level. Okay, if you get more patients to recruit themselves for screening, you got more patients to be aware of the symptoms of presence of microscopic blood in the feces. If you get more patients to be aware that this is a cancer that is getting more common in Malaysia, then you will have a paradigm shift. More patients will offer to be screened. Okay, so when you want to offer something for the population, you need to make it easy for them, more accessible, very convenient. Okay. So in the West, you even can mail your stool sample. In the West, you could email it. Okay, that means you're staying away. You just have to email it to the nearest health facility. But here in Malaysia, patient still has to travel, but they still have to send their stool samples. Okay. Okay. So up to now, I wish to touch another element of colorectal cancer, which I see that things are changing. Okay, last time people used to say you have stage 4 cancer, there's equivalent to death. Okay, so it's no more for colorectal cancer. Okay, it's not equivalent to that. It's still something can be done. Okay, so basically, when you talk about stage 4 cancers, it means cancer that has spread beyond the originating organs. Basically, it has gone somewhere else. Okay, it has gone to the lymph nodes. It initially goes to the lymph nodes, then it metastasizes. For colorectal cancer, commonest is still the lung as well as the liver. Okay, so why is there a change in practice? Because now we could remove the metastasis. That means besides removing the primary tumor, you could also remove the tumor that has metastasized to the lung, the tumor that has metastasized to the liver. And these have shown to improve the life expectancy. If you could remember my previous slide, 10 years ago, the life expectancy of a 5-year survival of a stage 4 colorectal cancer patient was around 17%. Now it is 30%, which is very good. So you have twice. That means you could still offer some form of therapy, aiming for cure, in which chemotherapy remove the primary tumor, remove the metastasis, and improve the survivability. Okay. So this is the evidence. Okay. So things are changing. You remove the primary, you remove the metastasis. Okay, and you improve the survivability. That is the main aim in cancer. Besides improving the quality of life, we want to improve the survivability of the patients. We don't want patients to feel that once they have stage 4, there's no more hope and they're going to die. Okay. So if you could see this line here, it shows the survival. Okay. So when there is no liver resection compared to liver resection, you could see the change in the diagram. The blue line shows better overall survivability in patients who had metastasis removed from the liver. Okay. So if you look at this, what is the survivability in this study? They noticed that it's around 50%. Okay, in colon cancers, in right-sided colon cancers, around 50%, left-sided 60%, but in rectum about 30%. So in summary, colorectal cancer, it's a preventable death. Screening, early detection, remove polyp, cure the disease. Basically, you remove the disease, remove the polyp before it manifests into a malignancy. Okay, all right. What are those with positive symptoms? Subject them for colonoscopy. Asymptomatic individuals go for screening fecal or cord blood test if they belong to the low risk group. Stage 4 colorectal cancer, not the end of treatment options. Okay, there's still more you can do. You remove the primary tumor, you can send them for chemotherapy, you can remove the metastasis. So what do I suggest? Advocate screening, offer them opportunistic screening, early referral for colonoscopy, and younger patients are also not exempted. So if you have a younger patient coming in with per-rectal bleeding, for example, at least the minimum that I would do a limited sigmoidoscopy. What is my cutoff age? 40 years old. Less than 40, no risk factor, per-rectal bleeding, it is still a limited sigmoidoscopy. That means I'll still pass a colonoscopy from the anus up to the sigmoid just to make sure the distal part of the colon is free of any cancers and then address the cause of the per-rectal bleeding. Okay. So basically, it's a very, for me, I think I spoke straight to the issue that we want to highlight about screening to improve our screening rate among the population and tell the patients that there's still hope, even if it's a stage 4 colorectal cancer. Okay. All right. So I think that's all my slide. Okay. I will pass the session back to Jason If you have any questions or any points that we can discuss, you have a lot of time. Let's discuss about it. Anything that you would like to clarify, make yourself clear. Any doubts, please feel free to ask me. Thank you. Back to you, Jason.
Yeah, thanks so much, Dr. Ussof. So I love it. We have a lot of time for Q&A because there are actually a lot of questions that are out there and there are a lot of things to discuss. Actually, just wanted to share with you, Dr. Ussof, NCSM, the National Cancer Society, we've been doing this colon cancer screening, FOBT. The whole of last year, we screened about maybe 15,000 people with just FOBT alone. So a lot of them came back. You'll be surprised, a lot of them actually came back positive. So about 1,000 patients, sorry, not 1,500 screened. 1,000 patients we screened. A lot of them came back positive, and there was one that we was very surprised. There was actually one that was very surprising. This is an old case, 25. Then when her name is Chu Meizi. She's one of our youth ambassadors for National Cancer Society. So she's a colorectal stage 2 cancer survivor. She's done the treatment. She's done everything, and now she's advocating for early screening and detection. She's now 30 plus already, have a PhD. So yeah, you are absolutely right. Colon cancer is not like a death sentence. Even if it's stage 3, stage 4, it's treatable. And like the case you shared at the start of 26, that lady with the painless bleeding, that's actually a very common thing that we see nowadays, huh?
Okay.
Yeah. So actually,
true, Jason. Yeah, I do agree. Yeah.
So there's actually a question now from the Docuity app. This is from a Dr. Kalyani. Is barium enema a good screening test for a 90-year-old? And another one is virtual colonoscopy better?
Okay. All right. So let's answer the first question. Is barium enema good enough? It's not good enough because you will miss small lesions. Okay, if your polyp is small, you won't be able to pick it up in barium enema. And barium enema was initially used last time in patients who cannot tolerate colonoscopy, or we couldn't do the colonoscopy for any reason. So you send the patients for a double contrast barium enema. If the lesion is small, you'll miss it in barium enema. Okay. And then that role of barium enema is now taken over by CT colonography. Okay, so basically when it's taken over, why is it taken over? Because the sensitivity is higher in CT colonography. So barium enema is out of favor. So when do you use barium enema? We hardly use it unless the patient has contraindication to do CT scan. Then we will do a CT colonography. If it's a 90 years old, okay, now let's talk about what is the average, what is the screening recommendation in the world now, okay? So even in Malaysia, we try to adapt the screening to start from 45 and you tend to stop after 75, okay? The cutoff is 75. But having said that, there are 75 years old, 76 years old, 77 years old who are very fit, who are very healthy, with who we will still offer screening because they are medically fit. And we feel that if you find any positive findings from a colonoscopy, you still can offer surgery because they are fit, okay? So for a 90 years old barium enema, if the patient has symptoms, I think, and she couldn't tolerate a colonoscopy, I would suggest a CT colonography at least if she didn't go for it. Okay. So is CT colonography better than a colonoscopy? No. Colonoscopy is still the best modality. Okay. There are instances where some patients they have very acute angulations of the colon. When we do the colonoscopy, we couldn't pass through certain angles and it's causing a lot of pain, discomfort with the patient, or you're afraid that if you force too much, you'll cause colonic perforations, then we'll subject them for CT colonography. Having said that, if you do CT colonography, you still have to follow them up closely because CT colonography has also missed lesions. Yeah, okay. So first is still colonoscopy, followed by CT colonography. Barium enema is almost never. Yeah.
Thank you so much, Dr. Ussof, for that. Dr. Kayani, I hope that answers your question. And just I guess just a curiosity from my end. For your end, how many colonoscopies do you get to do in a month in Sunway Velocity now? Like for the past few months, how many?
All right. Okay. On average, I mean, I'm still new. On average, I have around 2 per day. Okay.
Oh.
2 per day. Okay. All right. So but then it's not almost always it's malignancy. It can be polyp, it can be colorectal bleeding screening. It can be altered bowel habit. It can even be irritable bowel syndrome, inflammatory bowel disease. So there is a variety of causes. But when you have a change in bowel habit and you think that colonoscopy is warranted, with the consent of the patient, we will proceed. Okay, but not always that you get malignancies. Okay, all right. Yeah, but definitely polyp. Yes. Yeah.
Yeah. All right. There's another question from Dr. T. This is Dr. Swaran. He's a general practitioner here nearby. He was actually asking, Dr. Ussof, in your presentation, a lot of the symptoms and a lot of the things you described was for like more towards the left-sided colon cancer, but he feels that hey, there's a lot of things that wasn't talked about, like for the right-sided colon cancer, things like as a mass in the right iliac fossa. He's asking for a little bit more elaboration on that right-sided colon cancer part.
The reason why we see a lot of left-sided colon cancers because it's more common than the right. Okay, and then they tend to come earlier because they have blood in the stool, so they always come earlier. And sometimes because of the lumen size is smaller on the left side, they tend to come with partial obstruction symptoms earlier compared to the right side. Whereas in right-sided, the moment you feel a mass on the right-sided, that means the tumor is quite advanced. It can be locally advanced. Okay, and most of the time, what is the presentation? It's unexplained iron deficiency anemia, especially in male. Okay, so any patients who have iron deficiency anemia unexplained, that means she doesn't have any other cause of blood loss anywhere, chronic blood loss, and they have iron deficiency anemia, you must offer a screening colonoscopy. I tell you a real life scenario. Okay, a patient who has been admitted to a health facility for recurrent blood transfusion. Okay, he's 60 years old, recurrent blood transfusion. Every time he comes to the hospital, the HB is 5, 6, so he just get a few bags of blood. Yeah, he feels more energetic, goes back home, and this cycles repeats every 3 to 4 months. Okay, so one fine day, one doctor decided to refer for further investigation of the anemia. All you know, he already has stage 4 cancer. That means the cancer has metastasized to all over the abdomen, to the omentum, to the peritoneum. So, so if you could see this, what I would like to say is that don't treat the numbers, don't treat the symptom. You have to find what's causing it. Okay. So in right-sided, mostly comes with either they have melena or they have iron deficiency anemia. So then we will offer a colonoscopy. Okay. If they come with mass, most of the time it means it's locally advanced. Okay. And even that, we will still offer. Okay. If you could still resect, you could still resect. Okay. At this point, let me just talk about a bit of change of practice. Okay. Previously, when you talk about right-sided cancers, most of the time it's always surgery first. Surgery first. Okay. Now evidence have shown that even in locally advanced right-sided cancers, there is still role of neoadjuvant chemotherapy. Okay, so that means there was no role. There's no studies to say that you can give chemotherapy before doing surgeries for right-sided colon cancer. But now, no, you can still offer for locally advanced right-sided colon cancer. Still start off with chemotherapy followed by resection, downstage and resection. Yes. Okay.
Thank you so much, Dr. Ussof, for the explanation. So, Dr. Swaran, I hope that answered a little bit of your question. I hope that answered your question as well. So we have another one from Dr. Uma. Dr. Uma is a GP working nearby as well. So she was asking about anal polyps, I think with colonal polyps as well. So perhaps she's seen a lot of these cases, like when they come and bring it to her in the GP, they're asking, these anal polyps, even though they're initially benign and then they're already removed, can the same area become malignant, or can benign polyps become malignant, or like what are the features you look for? I mean, we do know the size, the calculator and all that, but perhaps you can just give us a little bit more insights on how it becomes malignant, polyp becomes malignant.
Okay, so okay, we talk about specifically about anal. Okay, so anal polyps. Okay, the commonest anal polyp are still skin tags. The commonest anal polyps are still warts. Okay, so basically warts will never become cancer. Skin tags will never become cancer. Okay, but then I also have to emphasize that you see patients with anal cancers. Okay, and anal cancers are relatively maybe underreported because patients tend to be reluctant to come because they feel very embarrassing. But I have to say we do see cases of anal cancers, and you have to accept the fact that there is how do you say, I would say, let's say, sexual preferences. Okay, so they still have some subgroup of the community. We have male to male sex partners. Okay, so they are more prone to develop anal cancers because it is really HPV related. Okay, so when you talk about anal polyps, first, it's still, the commonest are still skin tags. The commonest are still just warts. Okay, so what do we do? Okay, so I will still do a limited colonoscopy. Okay, and then if it's a if the anal polyp is disturbing, how does it disturb? It protrudes when the patient defecates. It bleeds when the patient defecates. Okay, so for that, I would advocate transanal excision. Just remove the polyp transanally and send it for histopathological. Okay, and almost always it will come back as benign, but there are instances where it is a squamous cell carcinoma of the anus. All right, but most of the time they are benign. So when do you when do you do offer surgery for anal lesions? If the anal lesions polyps are big, it's causing problem, especially when they defecate, it protrudes out, it bleeds. Okay, most of the time it bleeds because the overlying mucosa is very friable. So whenever the feces pass through, it causes bleed. So it's very inconvenient for the patient. We will offer for a transanal excision. Yes.
Thanks, Dr. Ussof. So understand the concept about anal polyps. Then I think like the other things that you also did mention in your slides as well, like if the size more than 2 cm, villus, number, and all that, and the dysplasia as well, that will cause increased risk for polyps to become cancers, right? So actually, Dr. Kayani, the initial person who asked about the 90-year-old, gave a follow-up more information. The CT abdomen and all that are all normal, but still having this abdominal bloating. So can a colonoscopy be done in a 90-year-old? Because you did mention about fitness, I believe you did answer, but she's asking very specifically for this 90-year-old, can a colonoscopy be done?
It can be done. Yeah, but looking at the description of symptom that she has, I feel that it's more of a functional problem in a 90 years old, right? So you see a lot of 90 years old coming with constipation, diverticulosis. So the symptoms are like that, very vague, abdominal bloatedness. They cannot empty their bowel regularly. Okay, so it sounds more functional to me, but can it be done? Yes, it can be done. It's quite safe to be done. Yes. Yeah. The risk of what is the risk of colonoscopy? It has less than 0.8% risk of colonic perforation. That means whenever patient going for colonoscopy, we will tell them you have a risk that you may perforate the bowel. Okay, so it is less than 0.9%. But having said that, it can still happen. So that's the only risk that I can foresee in a 90 years old, because their colon is chronically what do you call this, like what the symptom that she describes, it's like she has some form of partial obstruction. So sometimes the colons are filled with diverticulosis. It can be redundant. So that's the one difficulty that I anticipate, but it can be done. It can be done. Yes.
Dr. Ussof. So fortunately, there are a lot more questions. I won't eat up so much of the time. We'll probably end by 12-ish or so. So the next one again is by Dr. Swaran, who was the GP who asked earlier. So you mentioned about hereditary conditions that can increase the risk of colon cancer, and you divided the risk accordingly. But how about inflammatory bowel diseases such as ulcerative colitis and Crohn's disease? How frequently do we have to do like a colonoscopy for colon cancer surveillance in that sense? Dr. Swaran's asking.
Right. Regarding inflammatory bowel disease, okay, in this part of the region, we don't see a lot of patients with inflammatory bowel disease, okay, but we do see ulcerative colitis, we do still Crohn's disease, okay. Are they prone to colorectal cancers? Yes, and there are about 40% higher chances of them to develop colorectal cancer compared to normal population, because the mucosa is diseased, okay, and they go to repeated inflammation. So every time the tissue undergo inflammation, is a healing process. There's tissue death, and that causes apoptosis, and that predispose them to have higher risk of developing colorectal cancer. Regarding inflammatory bowel disease, the first and foremost therapy is still to control the disease. Okay, you control the inflammatory bowel disease. Besides improving the quality of life, you help the mucosa to heal, you improve the symptom and the patient's quality of life. And the colonoscopy schedule will depend on how bad is the colitis. Okay, when you do a colonoscopy in inflammatory bowel disease during the acute flare, you can cause more easier to perforate because the mucosa are very friable, the bowels are very friable. Okay, so colonoscopy interval in patients with inflammatory bowel disease differs according to patient, according to severity. Okay, if I may say, in patients who does not have any ulcers that is suspicious, you can still do it 2 to 3 yearly once. Okay, but if you have any suspicious lesions where you think that you need to monitor them more closely, or the biopsy came back high grade dysplasia, then you have to do it more frequently. Yes. So the colonoscopy interval differs according to the the inflammatory bodies. Yeah.
All right. Dr. Farhan, I hope Dr. Ussof answered your question. Well, I think he did a remarkable answering that question as well. So yes, colonoscopy follow-up is important in IBD. Okay. So a few more interesting questions. Would you like to get the question that's the most interesting first, and then we can taper down accordingly?
Sure, sure, listen, yeah.
So someone's asking about computer-aided colonoscopy or AI colonoscopy. How relevant is AI colonoscopy or computer-aided colonoscopy here in Malaysia as of now? Or how is that going? Is that something that people are looking at, or what's your opinion on that aspect?
Okay. All right. I think maybe what they're referring to, the AI colonoscopy, is what we call it as a capsule endoscopy. Okay, basically they swallow a capsule. There's a camera in the capsule, and the capsule will travel all across the small as well as the large intestine, and the image is later interpreted in the computer. Okay, so basically the camera will record the image of your intestines, and you have to retrieve that capsule from the feces and then get it for analyze. Okay, what's the advantage of that? We don't use capsule endoscopy to diagnose colorectal cancer because you may miss lesions. Okay, because the capsule is traveling, there is no remote control for you to control the movement of capsule from outside. It just moves by the peristalsis of the bowel. Okay, so and the camera may miss small lesions. Okay, and then sometimes if you have some amount of feces there, it may interrupt the quality of the image, so you may miss it. Okay. When do you use capsule endoscopy? Most of the time in our setting, we use it when you have undiagnosed occult GIT bleed. That means patient he is losing blood somewhere, but then you're not sure from where because you have ruled out upper scope and a lower scope, and you think that the bleeding is coming somewhere in the small bowel. Then we will use capsule endoscopy to delineate exactly where is the abnormal lesions in the small bowel for us to decide on which part of the segment of the colon which needs resection, the small bowel that needs resection. Okay, that's the only time that we use capsule endoscopy because we can't pass the scope, the colon into the small bowels. Okay, but otherwise, for the purpose of screening, for the purpose of diagnosing malignancies, not yet. Yeah.
Right. So I hope that answered your question about AI, Doctor. Thank you, Dr. Ussof, for answering that question. The next one is actually regarding tumor markers, right? The doctor's question was in his practice, he's seeing a patient coming for a screening, right? And because a lot of these places do tumor markers, so they get a CA that's raised, right? CA that's raised like slightly up to about 20 to 30. But the FOBT, the colonoscopy is always normal, but it's always in the higher end. So I guess is there a role for tumor marker CA in or any other tumor marker like in screening for cancer, and how do we better use it for the sake of our patients?
Okay. All right. Regarding tumor markers, okay, I have to admit when the patient goes for a health checkup or a health screening, right? So one of the package that is always suggested is to do a tumor markers. Okay, so they will send a set of CA125, CA1919, CA alpha fetoprotein. Okay, etc. Okay, let's talk specifically about CA. A raised CA is not equivalent to colorectal cancer, and CA is not used to diagnose colorectal cancer. Okay, CA is usually used as a marker of response to treatment. Okay, for example, if you have a patient who comes to you with colorectal cancer, the first preliminary baseline CA will give you a guide. For example, his CA was 40. So you expect that when you remove the cancer, the CA to go down, and you can use the CA in their 3 monthly interval follow-up later. So anytime the CA becomes more than 5, you have to ask yourself, why is the CA climbing now? Is there a possibility that he has a recurrence? Okay, that's the only time that we use CA in colorectal practice. Can CA be used to detect colorectal cancer? No, because it is not specific for colorectal cancer. Okay, but for example, if the patient comes to you with a blood test showing that, oh, my CA is 40, and then what would you suggest? Okay, I would still get a full history again, a physical examination. Okay, if the patient doesn't have any alarming sign to suggest that there's a possibility of a tumor in the colon, would I do a colonoscopy? I will tell the patient, okay, I might be a negative colonoscopy. There is two ways of looking at it. Either you repeat the CA and see the trend, is it going down? If it's not going down, it's static, let's do a colonoscopy. Or if you wish to have yourself a peace of mind, get it over by that, all, then you just do a opportunity to do a screening colonoscopy. But CA, a raised CA, it's not used to diagnose colorectal cancer. Okay. There are other tumor markers that we have. I mean, we do order, okay, but none of them are very specific to say that, oh yes, you have raised CA, you have raised tumor markers equivalent to cancer, except several. Okay, for example, if you have alpha fetoprotein in thousands, almost always there must be a liver tumors. Okay, so if you have PSA in the thousands, almost always there must be a prostate cancer with the bone mets or what. So then yes, but otherwise CA is not one of it. Yeah.
All right, so thank you, Dr. Ussof, for that. We are in the last few questions already. Maybe we'll take a last one and see how from there. So this doctor was asking, in his practice, a patient comes over with a genetic testing. Are you familiar, Dr. Ussof, with those genetic testings where they either take your saliva or your blood and say, oh, your risk for this is high, your risk is this is high, your risk is this is high.
Yeah.
So the question was, how do we counsel these patients with all this high risk of this cancer, or like colon cancer, specifically colon cancer, high for risk of colon cancer? Do we put them in category B and C already? Means in so 1 and 2 or 3 means like they are moderate risk or high risk already, just because they have this genetic testing? Or do we just say, no, this is just a genetic testing, it doesn't mean you have higher risk, just monitor as per normal?
Yeah. The thing about genetic testing is it just tells you that you have a chance, a risk of developing cancer, right? But I mean, for me, a person with a positive genetic testing is considered as moderate risk. Okay, so I will still advocate. I will still advocate for a screening colonoscopy. Okay, but that would be for me personally, it is a relief for myself and as well as the patient, because I don't want to miss the patient with has a cancer. At the same time, it's a relief for the patient because, oh, he got to know that he has a genetic risk of, okay. But if you look into the family tree very closely, as I've highlighted earlier, there's only 20% of the population which has inheritable colorectal cancer. So what we see, even in that 20%, if you look at the cell lineage, he is the only one. So you don't see a proper family tree. If you look at the pedigree, it's not there. So all of a sudden he has this germline mutation and he is the first index family member who has cancer. Okay. So having said that, if you have a patient who comes with a genetic test, unless it's an established one, like for example, like Lynch syndrome, yeah, almost definitely you must do a screening colonoscopy and OGDS. So the one that comes for a testing where they notice that they have a higher risk, I'll put them as a moderate risk and still I suggest them for a scope. Yes.
So
Yeah.
it's better on the side of caution.
Correct.
Right.
Yes.
Well, I think that was very aptly answered. Thank you, Dr. Ussof. And if you yourself, Dr. Ussof, or you have anyone you have cancer patients and they need support, just contact us. We've got offer free dietitian, free mental health, and we have a lot of peer support. We have a lot of women with cancer, men with cancer, and they can support one another. Because peer support sometimes is quite important. Sometimes they don't want to listen to the doctor. They don't want to listen to their peers. They're like, okay, okay.
Sure, sure.
Unfortunately, it happens. Okay, so there's a last question from, let's see who's this. Okay, so there's a last question. What are the role of NSAIDs for satellite lesions in colon cancer? NSAIDs and satellite lesions in colon cancer. That's interesting.
Yeah. So there was a hype. I think 5, 6 years ago, they were telling about was there any role of NSAIDs as a protective against colorectal cancers. Okay, so they were talking about NSAIDs use in especially they were looking at especially in patients with inflammatory bowel disease. No, so does that give them a protective against colorectal cancer. I would the evidence didn't really in favor. Yeah, that means it's not reproducible. It's not reproducible. So I think it's more harm using NSAIDs compared to the benefit. But then they were looking at a very subset, a small subset of patients with inflammatory bowel disease and everything. So I think it still needs a lot of discussion and research into it. It's not proven. Yeah.
Correct. Because if you look up the meta-analysis also, it's iffy at best, and even if there was also, it's a very small protective.
Correct. Yes.
So yes, I think that's about it. Thank you again, Dr. Ussof, for your time on this wonderful Saturday afternoon. We really appreciate you and your knowledge and even your delivery of all the information. Spot on.
Thank you. Thank you, Jason. Thank you for everyone who joined the discussion today. Thank you.
All right. Thank you, around. See you around.
See
Bye.
you around. Bye.